Happy Monday, everyone. Today, we're having a meeting about uh, your EALs. So that's why you're getting this recorded lecture to start chapter 21. We're going to be talking about like the management of the surgical wound. It's just going to bring in kind of some surgical techniques and principles, but also talk about uh, wound healing uh, and closure, talking about sutures and stapling devices, things like that. So go ahead and jump into it. Uh, Kind of our role uh, regarding the surgical wound. We're trying to protect it, from being contaminated, right? We don't want uh, microbes getting into that surgical wound. We're there to help, excuse me, with hemostasis, right? We're anticipating, we're watching the field, we're seeing if something's bleeding, then we're reaching over and grabbing a clamp or a clip, something, a tie, something that's going to help take care of that bleeding. Right? We help give exposure, by offering up retractors and things like that, and adjusting the lighting so that they can see what's bleeding and uh, what's going on inside that surgical wound. We help protect the tissue from injury. Right? We can uh, offer up laps that they can put into the surgical wound and help protect the skin edges and things like that from those retractors. We can help keep the wound moist too, not let it dry out. Becomes very important when working on the eye. Every so often, every about 20 seconds or so, you're going to want to be putting a drop of BSS in the eye to keep it from drying out. Uh, Helping eliminate dead space. Right, we do not want any pockets of kind of like this empty space inside the surgical wound, because that's just uh, kind of a harbinger for microbes and things like that. It makes it a perfect little environment for them. Now, Halstead came up with some principles regarding surgery that kind of work towards these things: as hemostasis, exposure, protecting the tissue viability. That's part of keeping it wet and things like that. Restoration. Uh, so, some of Halstead's principles are things like gently handling your tissue. You're not, when you put your retractor in, you're not giving all of your strength the entire time. You're just doing enough to kind of hold it back. Uh, Control that bleeding. Don't let things just bleed uncontrollably and then go and deal with them, later. All of that is going to help the patient in their healing. The less blood and stuff that they lose. Right, preserving that blood supply, making sure you're not cutting something that is a major vessel or something like that, or it kind of feeds into that uh, controlling the bleeding. Right? Meticulous aseptic technique. Your surgical conscience is very strong. You're constantly watching and making sure things aren't becoming contaminated, and that the proper techniques and stuff are passed, are followed when passing, like suture and instruments. You're not letting that string dangle, that kind of thing. Minimizing that tissue tension, right? You're not yanking on stuff. You're not, if you have a clamp on something, uh, like an Alice or something, you're holding on the tissue that you're pulling out. You're not yanking on that so hard that you're basically ripping it out. You're giving it a good amount of tension so that things free up, but you're not ripping it out. And then again, eliminating that dead space when closing a surgical wound. You do not want like the first layer closed real tight, and then the stuff that's in between to not be closed at all, and then you close the skin because you left like a little cave, basically, for microbes. Uh, so the kind of an injury prevention, right? We're not doing anything, you know, that we didn't, or didn't put down in the consent, right? So, uh, and the preventing injury kind of things. This is an example would be, putting a trocar into the bowel when inserting it into the abdomen, right? There's certain techniques and procedures and stuff that we got to follow to help prevent that from happening, but yet it still happens from time to time. So it should be something that we make sure we're following our procedures as far as insufflating uh, the abdomen with the proper amount of CO2 before we're trying to shove anything in there, making sure that we're looking and assessing, being very diligent about uh, what we're doing, make sure we've got the correct lighting and exposure and stuff like that. We can see the tissues. Uh, another way that we do things to prevent injury is if we're doing a big open abdominal case and we know that we're going to be down near in the pelvis, they may prophylactically, before the surgery, put stents in the ureters so that we can help protect those later in the surgery. If we're cutting a tissue, we know exactly where the ureters are and we don't accidentally cut those. Um, and the way that we help, this is we're having the right instrument and the right size of the instrument. We're not giving them something super, super long if they're working shallow, or vice versa. If they're working deep, we're not giving them something super short and they're having to struggle and fight and stuff like that. Always grabbing those instruments that are not being used. If they set them down on the patient, you're immediately picking them up and put them back on your Mayo stand, unless we're using that bowel technique, right? Trying to handle the body's tissues as little as possible. Because every time you grab or cut or anything like that, the body responds to that. So the more inflammatory processes we have going on, kind of the longer it's going to take the body to heal, right? We're using up a lot of that immune system and the white blood cells and things like that. The more and more we, handle the tissue and or things like that. So, and we can rest our hands on the patient, but we don't lean on them. We don't put like our whole weight. We're not like up at the bar, put a shoulder, an elbow up on them and like rest and things like that. So, uh, wound irrigation is important. We don't want the tissues to like dry out, which is why sometimes when they're placing like the big retractor systems, like the Bookwalter, the Omni, the Thompson, and things like that, they're going to take moistened laps and put them in between the retractor blade and the tissues that it's holding back. One, it's helping kind of protect that tissue from that over tension from the retractor blade. And two, those moistened laps will help keep that area wet. Not like, obviously soaking wet, but help keep those tissues moist so that they don't dry out, right, and dehydrate. Typically, we're using, like normal saline, except obviously you guys learned on the breast biopsy in the presence of cancer, we may be using more of the water for that hypotonic, isotonic, hypertonic solution mindset. Retraction, right? We're trying to give that exposure. We're trying to let them be able to see what they're working on. You can't see what you're working on. You can't, work on it, obviously, at least not effectively. We've gone over like these retractors, the handheld versus self-retaining, right? The advantages and disadvantages of both. Right? Your handheld, whereas you're having to hold it, and you're going to have eventual fatigue and things like that. You get that dynamic adjustability. You can move that retractor pretty much anywhere you want it and get good exposure. The self-retaining where you lose that dynamic adjustability, you gain back your other hand. You don't have to hold it. It holds itself open. And now you have both hands to work with. So, and then of course, you're picking your retractor based on, the depth of your incision, right? And how deep is the blade on the retractor? You're going to match up. Do we have, blunt tips or sharp tips? Is it, kind of a curved retractor, or, what's its size, and weight? Is it going to be, too big for the incision we made or too small for the incision we made? Some of you have asked, do you really want this Wheatlander? Because you have the little baby Wheatlander in your minor tray. Might not be good for a McBurney type incision. It's too small. Remember that the surgeon always places the retractor, and then you just hold it right where they give it to you. They'll say, here, hold this here, and you just take the retractor and give the same amount of tension, and that kind of thing, and then that's it. We never place the retractors. And then towing in, that's where you take the tip of the retractor. I'll show you guys this more in lab too. But you're going to lean it, kind of tilt the retractor. This is for handheld retraction. And that helps kind of like bring that front tip of it in more to the patient. That's what they mean towing in. But like I said, I'll show you guys that in lab so you kind of see it better. Hemostasis. Right? We're trying to control those bleeders. We can do that by suturing them. We can do that by putting a sponge and holding pressure. Right? It's a small enough kind of bleeding thing, just oozing. We can use instruments by clamping it off. Right? We can use the bovie, or we can even use for those instruments, we can use a clip to clip it. Right? We can use the bovie for electrosurgical. We can use those biochemical hemostatic agents, right? The Surgicel, the Avatine, those kinds of things. So we're just trying to keep as much blood in their system as possible. Because the more blood that they have in their system, then, the more platelets, the more, collagen and white blood cells and things like that are available to that patient to go ahead and fight and start to heal, right? The longer or the more blood that they lose, now the body has to recreate all that stuff that they lost before they can even start to heal. So they're already behind. Some methods of hemostasis, right? You have mechanical hemostasis. That's actually clamping onto something. Right? Then you have thermal hemostasis. That's using the bovie or heat, right? Thermal. Or even or using some kind of temperature, right? Because you can use cold as well. You can use cryotherapies, not used as often, but you can use cryotherapies to get a hemostasis as well. And then you have the chemical means, which is those hemostatic agents, so Surgicels, Avatine, gel foam and thrombin, right? Suturing is considered a mechanical because you're doing some action, right? You're having to suture or you're having to clamp something. Those are mechanical. But taking the bovie and burning it, that's that thermal, and then just putting some kind of hemostatic agent on it is chemical. Remember those because in your case studies in clinical, there's a section on the case study where you talk about how you achieve hemostasis. And you got to check off mechanical, thermal, or chemical. And you make sure you understand which method is which. The physiology of coagulation. So this is how do we stop bleeding on our own as our body, right? So it immediately happens when a blood vessel is injured, or even when the body is injured, right? Because As soon as you're injured, you start bleeding. Obviously, a blood vessel has been injured because now you're bleeding. Right. So first, what happens is the inflammatory response kicks in. So what that means is now the signal is being sent to your brain. We have an injury. So your brain immediately sends out all the signals, send white blood cells, send platelets, send all this stuff to that area so that we can start repairing. Well, you're going to get a vasospasm. Those vessels will start to kind of spasm up. What that's doing is it's kind of twofold. It's sending out that signal, hey, there's an injury, and two, by it spasming, it's kind of closing off and letting less blood out. Now, as the platelets come into that area, they're going to form a little plug, and then that's going to even slow the bleeding more until. Now, granted, this doesn't all happen, like within 5 seconds, right? But within those 5 seconds, all of this has started. The body has got the signal, sending out its own signal. All of these things, these platelets and collagen factors and all that kind of stuff, the matrices and all are all headed, white blood cells all headed to that injury location to begin healing. With your hemostatic agents, those are just helping that coagulation process, right? It's giving it more fuel and more material to help build that plug and stop that bleeding and start that healing process. Because once you've gotten the bleeding stopped, now the signal of injury isn't as intense going out to the brain, right? You're not losing anything anymore. So now things can kind of calm down a little bit and take their time. Right? Some of the items that you need to become familiar with as an ST are these, like your active hemostasis or chemical hemostasis type things, like your Surgicels, Avitine, gel foam and thrombin, things like that. Gel foam and thrombin will go more into like a flowable as well. It's you take kind of this powder and you mix it with thrombin, and it turns it into almost like a gelatin that you can squirt onto a bleeding area and then put a sponge over the top of it, and that'll help coagulate. And then like these sealants, they're almost like a glue for inside the body, made out of fibrin and things like that. So then the body naturally absorbs it, that kind of stuff. It's not some foreign material that's going to just cause a issue with the body or something like that. And then there's two separate pathways that you can get to coagulation, or the way that coagulation gets activated. You have an intrinsic pathway. Those are activated by factors that are already in the blood. And then you have the extrinsic pathway that occurs in the actual tissues themselves. So you have intrinsic pathway that's running through the blood. This is like that coagulation, kind of like cascade. This is where, as more and more platelets and coagulants get to that area, it's kind of like a positive feedback kind of loop, right? It's as more are coming in. Hey, do you need more of us? Yes. So more and more just keep coming because you have those factors in the blood that are picking up that signal and sending it back again. Okay, more. The extrinsic, that's happening in the tissues. Those are those tissues when they get injured, sending off that signal to the brain. Hey, activate the coagulation. We talked about this, right? This absorbable gelatin, right? That's that gel foam and thrombin, right? The oxidized cellulose, that's that Surgicel. You've got some absorbable hemostat stuff, bone hemostat, that's like the bone wax. We talked about that. One of the things to be wary of about bone wax is that if the patient has an allergy to bees, then it may not be a good idea to use the bone wax since it's made from beeswax. And then another thing to understand here too is the cell saver. The cell saver is a machine. It's basically a suction machine that you use in the operating room. Um, what it does is that it, as you're sucking up the blood and stuff like that from the patient, it's taking it to the machine and it's spinning it down through a centrifuge, and then only pulling out like the red blood cells or the patient's own blood, and spinning it down and filtering it out. And then you can give that blood at the end of the case, or even in the middle of the case, if you're still working on them or something like that, you can give that blood back to that patient. So they're not losing their own blood. I mean, they're losing it out of the system for a time, but once you gather enough of it, then you can filter it down and give it back. So that's what the cell saver does. Usually done on like, total joints, big abdominal case, something the patient's going to lose a lot of blood during that surgery. So we use that as kind of a precautionary thing, a way to give them back their blood. You got, your ESU, right, or BOVI, electrosurgical unit, right, that can provide your hemostasis. Remember, that's thermal hemostasis. You also have the tourniquet, right? You put a tourniquet on a arm or a leg or something like that. Your goal is to have a bloodless surgical site. And then when putting on a tourniquet, there's a rubber, kind of a rubber band item that you have to have on your field. It's called an S mark. It's like a little tube, a little roll of rubber band material. And you're going to wrap that around the limb from distal, which means furthest out, to proximal. So you're always going the furthest away from where your tourniquet's hooked up at. And then you're going to wrap this rubber band as tight as you can from fingertips, if it's on the arm, from fingertips up to wherever the tourniquet is on the arm. And the reason that we do that is we're doing a process called exsanguination. If you guys remember SpongeBob and his imagination, think of it that way, exsanguination. It means to remove the blood. So what we're doing with that rubber band is we're wrapping it around that arm real tight, and we're doing it from distal to proximal because we're pushing the blood that's out in the fingertips back up the arm to the other side of where that tourniquet is. And then once we wrap all the way up to the tourniquet, then we inflate the tourniquet. And since we've pushed all that blood out, now when we make our incision, the patient shouldn't bleed. Right? And that auto transfusion, that's cell saver, right? Transfusion from self. Or what you also can do is you can go in, if you know you're going to have surgery and it's scheduled out and stuff like that, you can go in beforehand and have some blood taken so that if you need to get blood during surgery, they'd just be giving you your own blood. Sponges, right? We've talked about a few of the different kinds of sponges, right? You've got the Ratex. Those are the smaller 4x4s. And then you have the laparotomy sponges, or the laps, right? Those are the bigger ones, absorb a lot more, right? It says here only mounted 4x4 should be on the field during a major case. What that means is like your sponge stick. If you're going to have 4x4s up for a major case, like a big open belly or something like that, then those Ratex should be on a clamp of some kind. And then you have your sponge dissectors, right? You have peanuts, Kittners, usually put onto a clamp so that you can do more blunt dissection with them. Typically done more in the neck area. is where you'll see these peanuts and kidners and things like that. Um, the round sponges, these are going to be like your tonsil sponges, things like that. They'll be round, like spherical shaped sponges, and they're going to have a string attached to them, make it easy to pull out. Cotton balls, right, usually used in neuro, uh, is to help kind of, you can dip them in like, some topical thrombin or saline, is to help keep those tissues moist. Uh, a lot of times I've seen the cotton ball, you dip it in the saline and get it all moistened up, and then you're going to place it underneath the skull flap or the skin flap for the skull, so that the tissue underneath the skin and everything underneath there doesn't dry out. And then you've got like your cottonoids or your neuro patties. Uh, they come in many different sizes, little half by half inch squares up to 3 by ½ inch rectangles, 1 inch by 1 inch, I think 3 inch by 3 inch. They get pretty big. These are all just, and they all have a string attached to them, like your round sponges. Uh, Mainly used in neuro down in those deep incisions and stuff in the back, and the string is there so you can pull it out, retrieve it easily. Sutures, right? The whole reason we use sutures is kind of a twofold thing. We're either approximating tissue, bringing tissue together, right? Or we're ligating. We're tying off something, right? We're stopping bleeding. Uh, Sutures can be kind of difficult because uh, just like just like anything else, I think that you're finding here in the medical field is that there's certain things that can be used for multiple different areas, right? And what I mean by that is uh, that a surgeon can use one particular instrument for one case, and then you work with another surgeon and you try to hand them that same instrument, and they say, oh, I never use that. This is how I do mine. So with this suturing, you can use different types of sutures to accomplish the same thing. It's all going to depend on what that surgeon is most comfortable with. And what we have to learn is what are the more common type sutures that you use in certain situations, right? What type of tissue are we working on? That's going to kind of dictate some of the suture that get used there, right? Are we working on delicate tissue like blood vessels and things like that? Are we working on mucosal type tissues? Are we working on muscle or tendon, that kind of thing? So uh, it's one of the reasons why suture is a little bit more difficult to learn, is because there are a lot of different variables that go into it. But the bodies that regulate sutures is the FDA, Food and Drug Administration, and the U.S. Pharmacopoeia. Um, and like you can have a 4.0 Vicryl on a PS2, but then have a 4.0 Vicryl on a PS1. That's like, why do we use one versus the other? They're both the same size. The needles, one needle is just a touch bit smaller than the other one. We're using it to suture the skin, so what does it matter? Some of it's going to be comfortability of the surgeon. Other times it'll be a more practical type reason. So, uh, so some of your physical structure, right? This is what you actually can see and touch, right? You have monofilament sutures, which means it's all one single strand. It's all the same thing. It's all uniform. There wasn't any kind of adding in or mixing of uh, different strands or anything like that. Multifilament, that means it's got many different fibers to it. Now those fibers can be like twisted, as you see here. It can be braided, like you're braiding your hair, or it can be a composite where you have the middle of the suture, the inside of it is all one material, and then you have something over the top of that that's another type of material. So that would be considered multi-filament because it's not all one same thing, right? Um, and usually those braided or twisted sutures, they're going to be coated with some kind of like Teflon or some kind of chemical over the top of it to reduce friction. So as you're going through tissue, it just slides through easier. However, because you have multiple strands, it's going to make it a little bit rougher on the tissue. So typically, those multi-filament are going to be used on tissues that can withstand kind of that extra friction or tension to them. Your suture size, it's based on the diameter of the string, remember. Typically, your sutures range from actually 12-0, which is your smallest, up to number 5, which is going to be your thickest, like rope, right? And then you also have stainless steel sutures, so they're actually metal string, I guess, if, for lack of a better word, right? That's coming off of the needle, typically used to suture back together the sternum after open heart surgery, right? But they use the Brown and Sharp sizing system. Your tensile strength. This refers to how much force you need to apply to that string to break it. Right? So if you're using a number 5, you've got to apply the most amount of strength to break that. If you're using a 12-0, you're probably just, a couple fingertips. Right? Some of your tensile strength is going to be influenced by the type of knot that you use, the biological environment of the patient, right? The area which you're using that suture. Was there a lot of infection or microbes and things in that area that are going to get absorbed into that suture and potentially start to break it down, right? Uniformity, right? How, as far as that string being made, do you have this? Is it uniform? Is it nice? You have the same material or amount of material in the end that's closest to the needle as the very tip of it, and all the way throughout. Is it nice and uniform? If there's any kind of and same thing with your suturing technique, right? Are you putting more tension on one area than another? Did you take a bigger bite of tissue with one pass than another, right? That kind of thing. That can start to break down those because you're putting tension on one edge or one area of the suture versus another. Also understand that the weakest place of a suture is at the knot, because once you start tying them together, now you're putting that stress and strain on the actual string itself at the place of the knot. So you've reduced its tensile strength right there at the knot. So remember that the knot itself is the weakest part of your suture. Suture handling, right? That kind of compliance or pliability. How easy is it to kind of move around, right? Does it kind of hang for itself? Does it kind of flutter out? Does it have what's known as memory? A lot of your monofilament type suture is going to have what's called memory. It's remembering how it was packaged, right? It's got all the little loops and stuff in it. So when you take it out of its package, it's going to try and bind back up and go back into that shape. And what you have to do is kind of stretch it out. If anyone's ever decorated like a birthday package or balloons or something like that, and then you have the little string off the balloon. If you take the edge of your scissor and you run it along it, it'll curl it up for you. It's the same thing with monofilament suture. It's already curled up. You're trying to get it to straighten out. So usually when you load up a monofilament suture, like a nylon or a Proline, something like that, you'll load it up on your needle holder like normal. And then as you're taking the strand out, you're going to just kind of put your thumb up against it and just let it drag kind of across it, and it'll help straighten it back out. So you'll have this nice straight suture when you hand it to them, rather than this whole ball of stuff that comes, bunching up near the needle holder, which can cause knots and stuff like that in your suture while you're trying to suture, causing a problem. And then the plasticity, right? How well does it bounce back from, being molded and things like that? Like your stainless steel suture does not have very good plasticity and has tremendous memory, because you can bend it into a shape and it'll stay there for you. Right? And you got to straighten it all out. If you too much bending, and you can have this, messed up wave in it, that'll make it really hard to get through the bone and you're trying to suture. So, now we talked about monofilament, multifilament. Now we're going to talk about absorption, right? Because you can have a monofilament non-absorbable suture, or you can even have a monofilament absorbable, a multifilament non-absorbable, or a multifilament absorbable. And what this means is that it's talking about how fast the body absorbs that suture material. And typically, if it happens, within, I think, like a 6 to 8 week period, it's considered to be absorbable. Anything beyond that, they're starting to now, they say it's a non-absorbable suture. It's going to hang out for a long time, like up to a year or longer, before the body can break it down. And you have natural absorbables like your plain gut, chromic gut. You also have synthetic absorbable suture materials, right? But the same thing goes for non-absorbable. Like I think silk, like the silk ties and stuff you've been using, those are non-absorbable, which is why we use them to tie off blood vessels, because it's not going to absorb, and then that blood vessel will be open again, right? But silk is something that you find in nature, non-absorbable. And you could also have synthetic, naturally made one, or man-made ones as well, like your nylons, Proline, things like that. Capillary action. This talks about the suture's ability to absorb fluid, right? To bring in fluids and stuff like that. Because, and it's not just like saline. I'm talking about the body's own fluids, right? And it absorbs that up. That capillary action will swell that suture and could actually cause it to break, to break down and stuff like that. So, and then bioactivity, this is the body's response to that suture, right? The chemical, the chemical makeup of that suture, what it's made out of, is that going to react to the body, or is the body going to react to it, and see it as a foreign thing that it needs to get rid of? A lot of this happens with Vicryl. The patient does what's known as spitting the suture, right? So they'll put some Vicryl in, below the incision side line, right down deep, to eliminate that dead space, and then the patient will show like little redness and swelling, maybe some heat and stuff like that, and then right up at the incision site, all of a sudden they get like this little kind of like pimple or boil or something like that, and then actually the body will spit out the little knot of suture of Vicryl, because it was reacting to it, and it decided, hey, it's got to go, right? There is one type of suture material that will not break down in the presence of infection. And that, we're talking that capillary action there, right? If you're absorbing like infectious fluid and material and stuff like that from uh, the wound site into the suture, it's going to degrade that suture and break it down. So the number one suture that gets used in the presence of infection, if you're actually going to try and close that area up, or the best suture to use, is the stainless steel, because it has zero capillary action whatsoever. It's metal. It's not going to absorb fluid. So therefore, if you have an infection present, then surgical steel is your best option. Now, it's not always going to get used because you need like bone to really hold steel together. So typically, if you come across like a big abdominal wound or leg wound, something you're not going to be able to use surgical steel to close, those are the types that we'll use, like the wound vacs, or we'll have them heal by secondary intention, right? That inside to out healing. Absorbable sutures, right? That's your plain gut. Those are your and chromic gut. Those are your natural absorbers. You also have those absorbable polymers, right? Typically, these absorbables are going to be used in an area where the tissue heals quickly. Mucosal, and sometimes you see with regard, say, to the intestine specifically. So some surgeons, when reanastomosing the intestine, will use Vicryl. Some use silk. Silk is a non-absorbable. Vicryl is an absorbable. When they were first doing like bowel resections and reanastomosis and stuff, they wanted something non-absorbable because they didn't want it to come apart, right? And then they got better with the absorbable stuff and things like that. I think the invention of Vicryl came out because you couldn't use the plain or chromic gut because it absorbed too fast, which is why I think they switched over to use something non-absorbable, because then it doesn't absorb and you don't have to worry about there being a reopening of the anastomosis or the surgical wound. So, but with the invention of with the invention of Vicryl and things like that, now it takes longer to absorb, but it still absorbs. Here's your non-absorbables, right? Silk, nylon, polypropylene. That's Prolene suture, right? Stainless steel, right? These sutures, but you just understand why you would use a non-absorbable versus an absorbable. Right? If you're dealing with tissues that heal quickly, mucosal membranes like in the mouth, intestine, esophagus, stomach, right? Anywhere that's like a digestive system. Typically, we're looking at mucosal membrane, which is why Vicryl is one of the most popular sutures used, because we do a lot of digestive surgeries and we're working on a lot of mucosal membranes. So we want something absorbable to work on those membranes with. But then as far as non-absorbable, if we're doing anything vascular and we're trying to ligate off a vessel, we don't ever want it to bleed again. We don't want blood flowing through it at all. We should be using something non-absorbable so that it doesn't ever absorb in and then that lumen gets to reopen. Right? So some of the variables behind what suture we're going to use and stuff like that. What's the tissue looking like? Right? Is it able to even hold suture? Right? Is it so uh, infected, that the suture, that the tissue itself is just falling apart. Right? How much healing time are we talking about here? Is this going to take a long time to heal, 6 to 8 weeks, like bone or tendon and muscle? Or is this like maybe a couple weeks or a week and a half or something like that, like mucosal membranes? Or, I mean, if any of you have ever bitten your cheek when you're chewing or something like that, right? You're like, oh, and it's like usually 4 or 5 days later, you're feeling over and you can't even tell that you bit your cheek, except for like that kind of sore spot. You're like, oh yeah, there it is. But when you feel the inside of your cheek, it feels just fine, right? Uh, what kind of required strength do we need to have on that suture during that healing time? What's the tensile strength need to be, right? Because if it needs to be 10, and we need it to last at 10 for say 7 days, and a day 4, it's going to be an 8, it may not make it all the way to 7 days. Right? Um, the things you also have to still take into account when we're talking about this required strength during healing is those patients are going to be up and moving around and stuff like that, right? So they're going to be putting their own stressors on it. So we have to kind of take that into account too, right? We want next to no scar formation. Some of that is suture selection, but a lot more of that is the technique that's used in closing and approximating those tissues. Right? Are we working on the urinary tract? That's another mucosal area. Right? What's our risk for infection? Right? Is this an area uh, that's close to like some dirty areas or things like that, or that has a good potential to be infected? Maybe we should pick a different type of suture that's going to be able to withstand an infection or withstand an infection a little bit better. Obviously, you're working in an area that there's a high risk for infection. We're talking near like the mouth or the anus, something like that, or even like near a colostomy site. You're not. These are areas that you're not going to be using that surgical steel, but you can still choose like a monofilament, non-absorbable kind of suture with like a low capillary action, things like that. Maybe in that area if you need to. Um, are we working on the skin? Right. What type of technique are we doing? Interrupteds on the skin? Are we going to be doing more of a subcuticular stitch? That's going to kind of change up what suture you're going to use, and you can understand now why this can be difficult for students, right? Because you're like, what do we what? Like all these different things have to go into it, and we got to think. I don't want to think. I just want to here's your stitch, use it, right? Um, a lot of this will come to you as you do more and more surgical procedures and things like that, and the understanding. Basically, what some of the big points you want to understand is that the bigger the number on the suture, typically the deeper in the body you're going to use that item, especially when you're closing layers when the procedure is over and you're trying to come out. And then the smaller your size of suture, the more delicate of tissue you're working on. The needles themselves, they have their own parts, right? You got the point. That's that sharp point that's going to go into the actual body, and it doesn't have to be sharp. Because there are blunt needles, but it's the end that goes into the tissue, right? You have the body. That's the big curvature of it, and then you have the eye. This is where your string is attached. Typically, we don't use eyed needles anymore. This is like your sewing needle, right? Where you're going to take your thread and feed it through and then tie it off to it. Where we call the eye of the needle now is where the thread actually is swedged on or connected to the needle. But there are some needles out there, they're free needles, that from time to time we need to use. that are eyed. So we do load the string. We would just take a tie and load it in onto the needle. And you always go from the inside curve of the needle when you're loading the suture. You always go from in there first and then come out the other side. So that way, as they're suturing, it stays in place. It doesn't pull out with the tissue. There's different types of the eye needles, right? You have a French eye needle, which means it just has like a split down the middle of it. It's not an enclosed, like the closed one. So it's not like a loop of metal that you feed it through. It's just kind of a deep groove, and then it has different section of it stick off so that the suture doesn't just go straight in and out. It's got to get hooked. It hooks onto those little pegs that come through. I'll show you guys an example of the French eye one in lab. And then you have the atraumatic eye. That's that swedged on, right, where the suture is loaded right into the back. And then you have the control release, right, or pop off sutures. Those pop offs, it means that string, you just give a little pull and the string will come directly off of the needle. The swedged on, I think I told you guys this before, you got to have your Wheaties. You can do it. You can pop that string off of that needle, but you really got to give it some force. And then I showed you guys the double arm needle. That's where you have that one piece of string and then you have a needle on either end of the string. I typically used for vascular surgery. The needle size itself, they're looking at the diameter of the shaft, and then the dimension from the tip or the point to the eye, right? And those needles, the sizes are going to depend on the suture or not suture, on the tissue that you're working on, right? If you're trying to repair muscle, you're going to need kind of a heavier, a thicker needle, and then the dimension from the point to the eye will be dependent upon what kind of approximation do you need to do, how far apart are your tissues, right? So, and that what it means, that dimension from the tip to the eye, that's how big the U is, right? You get some of those needles that are really long and have a big U to them, and then you have other needles that are like really narrow and don't have like a whole lot of space between the tip and the end or the eye. So your point can either be blunt, right, which means it really does not come to a point. It just comes to like a flat end. That needle is typically used on the liver. If you have to suture the liver at all, there's a liver laceration or something like that, you were using a suture with a blunt needle. The reason is that the liver itself is very frail and what's known as friable, which means if you take that sharp, as soon as you stick it in, now you're going to make it bleed from where you stuck it with the needle. And every time you're sticking with the needle, it's now bleeding from that spot. And what you're trying to do is get the liver to stop bleeding. So that's why we use a blunt. The tapered needle means that it starts at that fine point and then it kind of gradually rounded and gets just a little bit bigger until it's the same size as the suture needle, or I'm sorry, the suture string. Right? Your cutting needles, and I will show you guys all this in lab. We'll have to get real close up on the needle so that you can see it. But these cutting needles, in the inside curvature part of the needle itself actually kind of comes up to a point, almost like a little pyramid. And that edge is sharp, and that's a cutting needle. So as it goes through, it's not creating just this perfect hole. It's got like a hole with a little slit to the side because of the inside curve of that needle. But then you also have ones that are what are called reverse cutting,
and the outside curve of the needle comes to that point. These are typically used on like skin sutures. The needles used for sutures used on the skin and things like that have this cutting needle because that works best for those tissues when when approximating them and things. Your tapered gets used more on your more delicate tissues, intestine, things like that, because and like your blood vessels and stuff, because you do not want that hole to be bigger than just the size of that needle, because you're not trying to have things leak outside of it. Suture storage, right? You guys have seen some of the individual boxes on the shelf. Those boxes will have that same information that's on the outside of the package, right? Size of the suture, name of the suture, uh, whether it's monofilament or multifilament, absorbable or non-absorbable, the needle on it, the needle that's on it, the number of sutures in per package. All that information and stuff like that is right on the outside of that box. Typically, sutures are kept in like the core area or a substerile area. Yeah, they can also be kept in the room in the closed cabinets. It's so that when you need suture, you're not having to run out somewhere to go get it. Things are close by. You can also have like a little rolling cart uh, that you bring around that's got like a different variety of sutures and things on it uh, that are typically used for those services. So that little cart could be like the ortho sutures or the vascular sutures or general sutures and things like that. So that now you're not having to run all over the whole OR department going back and forth trying to get sutures and stuff as they run out or need more and stuff. You have that little cart and you can just pick from that, and that cart becomes a little easier to restock and stuff. Uh, Packaging, right? First, you're trying to protect the project or the product that's inside, right? You got it in like its wrappers and its box and things like that. You're trying to keep the item sterile, right? But you still need to make it easy to open. So that's why they put it in those little kind of like peel pack styles. And then, they write all the stuff on those boxes stuff so that you can help, or it helps you pick it out easier, right? You're not sifting. You guys have been sifting through those bins, right? Looking for some kind of Vicryl or monocryl or chromic or something like that, right? To do these appies and stuff with. And you're having to dig through a bunch of stuff, but out in the real world, everything stays in its box. So it's just easier to look. Some of them are also color coded. Like your Vicryls are going to be in pink and white boxes. Your chromics in that brown box. The plain guts in a yellow box. The prolines in a blue and white box. So it makes it easier visually as you start to learn your sutures. Oh, I need a Vicryl. Okay, I'm looking for purple and white boxes. Okay, that's all over here. Okay, and then you're narrowing it down. Right? Minimal packaging. They kind of tout this as one of their things. They're trying to be environmentally friendly. That's the whole reason for it. Right? They're reducing the amount of trash that gets used because they know the suture is going to get opened and used a lot, a lot. Right? So you pretty much have suture for every case that you do. Uh, yeah, reading that suture label, right? It's got the name of the suture, the size of it, the color of the suture, right? Like you guys saw the Ethibond, it said green braided, right? Some of your Vicryls will say dyed, which means they're purple. Right? So the Vicryls, when they're dyed, they're purple. When it's undyed, they're just plain white. Typically, uh, they like to use the undyed because it's not as reactive with body tissue than the dyes. It'll have your type and size of your needle, the lot number of that, however that was manufactured and stuff like that. In case there's an issue with one of the packagings or something like that, then they can track those lot numbers and try and get those back off the shelf before they get used on patients. And then there's an expiration date, because especially like on your chromic and your plain gut and things like that, things that are absorbable sutures, and ones that are definitely being soaked in alcohol and things like that, they have a shelf life. They're not going to last forever before that tensile strength. They can't guarantee that tensile strength and stuff anymore like that. It's going to break easier on them. Typically, you don't really see this a whole lot because suture does get used so often. It's usually when somebody finds like a box that was hidden in the back or something like that or whatever, and it's got like a month left before it's expired. Then you're like, oh, and you start to see like why that stuff should get used relatively quickly. The way that you're going to get some of your sutures up, right? You're going to have, sutures with needles on them. Right? You have free ties, right? You'll have multiple, sutures in the same package, right? Those control release. You could have a couple of different strings coming off of the same needle, right? The suture reel. Some of you have seen it. It's just that little spool that's got the long tie on it that they can use over and over again for ties rather than getting a brand new tie every time. Right? You got the multiple suture packs, right? You have double armed sutures. You have those control release and or pop off, right? Some packages they'll come with control release sutures, and you guys have seen the big square package ones where you can put those needles back. Well, you have other ones that come in the same packages as like your chromic and stuff, but they don't come in, and they're pop off, but they don't have like a little container system for them. So they're just kind of like free and out there. So you have to be a little bit more careful with those and securing those for your sharp safety and things like that. So we're going to go ahead and pause there. And then when we get back into this on Wednesday, we'll get into the different types of suturing techniques. And how we, pass it and move the suture around and things like that to, minimize waste and contamination and stuff. Guys, keep making sure you're working on your EALs. Hopefully, we have an answer for the EALs after today's meeting, and kind of a universal, and we're all on the same page as far as Concord goes, as to how this is all playing out for you guys. Remember to get your assignments turned in by Friday night. I had a couple that did not make the deadline of getting their assignment turned in, so we've had to take zeros on that. They're not playing around, guys, and I really, really do not have control of these due dates and stuff like that. So at this point, I'm just kind of a facilitator. So really use those time management tools that I sent out. Sit down, have an honest conversation with yourself. Really fill that out honestly and stick to it. Say, hey, I've got 45 minutes here, or I've got 20 minutes here to do this or do that or whatever. Take those times, get those things done. I think every single one of you has great potential to be an awesome tech, and I do not want to lose any of you due to missing a due date on a couple of assignments or something like that. So, all right, that's my spiel on that. I'll just say EAO one more time. EAO. Good. You guys have a great rest of your night, and we will see groups B and C tomorrow in the lab.